sir is done with the presentation.
Yeah. So now the next step is basically how we are going to plan our CT scans. So CT scan reading is actually a ocean. We have so many points, and I'm going to brief you on how we're going to read CT scans. So I'm going to share screen, put my previous. So how do we read CT scans? Yeah. Now basically, this is already there on YouTube. Of course, I just want to show a few things. How to read a CT scan. The first thing is read the CT scan from the first cut. Nowadays, there are so many DICOMs available. The soft copy of the CT scan, then the hard copy of the CT scan. So I want to ask what I prefer, whether I prefer the hard copy or the soft copy. If you have a computer screen in your theater and you are able to back and forth move it, then I think the soft copy is better. Or else I'm old timer, I always prefer the hard copy of the scan. This is the first point I want to convey. If you have a navigation, it's a different ball game. But if you don't have the navigation, I always believe that the hard copy is the best for reading the CT scan. You might actually be wondering, nowadays we are progressing and you have DICOM softwares, and why should you have? So basically, the memory of an individual, for example, your stored memory, you have read a CT scan and you are going to operate, right? On the left side, the right side. When you operate, you would like to see what you're going to do in the frontal sinus. What is the cell you're going to deal with in the frontal sinus? And at that time, your memory might fade off. You don't know what cell you're going to deal with. So at that time, it's better to go to the X-ray lobby. X-ray lobbies are always there in every theater. It's better to have a hard copy. But if you have a computer inside your own theater where you can scroll on to the soft copies, then you can put that particular cut and then use the soft copy. So this is the first point I want to convey. Always have a hard copy, or if you have a soft copy, always you should see the scan when you are operating. The problem with the soft copy, what is the problem with the soft copy? You can only see one cut. That is, you can only see that particular cut. And you cannot plan all the cuts simultaneously. But basically, in my opinion, I always create a scene. That is, I create an Z-axis in that 2D image so that I can actually visualize the whole recess. So frontal recess or whatever. So I love having, I have seen many theaters where they don't have hard copies at all. Nowadays they say, sir, I have only a CD. I don't have a hard copy. I just tell them, go and get a hard copy. I want a hard copy when I operate. So this is my first point. I want to tell you that when you have a hard copy, see, imagine, you know this rule of dozen, right? What is the rule of dozen? Rule of dozen means the distance from the anterior lacrimal crest to the anterior ethmoidal artery is 24 millimeters, right? From the anterior ethmoidal artery to the posterior ethmoidal artery is 12 millimeters. From the posterior ethmoidal artery till the optic strut is around 6 millimeters. So 24 plus 12 plus 6, how much? Tell me. 24 plus 12, 36 plus 6, 42. So 42 divided by 3. How much is it? 14. 14. So that means you need 14 cuts. A 3 millimeter, 14 slices you need. Apart from that, you take 2 slices or 3 slices in front. Have 3 slices. So you have from the nasal tip to the anterior lacrimal crest 3 cuts. That means 14 plus 3 is 17. Then you have 3 cuts behind the optic strut if you want to see the foramen ovale. So that means a scan hard copy having 20 cuts. That is on a 5 row, 4 vertical, you can cover the whole sinuses. So that means a scan having minimum of 17 to 20 cuts. Should be your target. So believe me, I don't find any difference in that 0.625 or 1 millimeter cut. It doesn't make any difference. 3 millimeter cut is more than sufficient for you to actually read a scan. That means you need 16 to 20 cuts. So even if you have 5 rows or 4 frames, 4 rows, that is more than sufficient for you to read a scan. So when you see a scan, don't think that I need only a 0.6 millimeter cut or 1 millimeter cut. 1 millimeter cut means, imagine the whole distance will be from anterior ethmoidal artery till posterior ethmoidal artery, we need 24 cuts. Believe me. Imagine how you're going to see all the 24 cuts. It's not possible. Believe me. You cannot have 3 scans and read all the 3 scans hard copies. Of course, you can do that in the soft copy, but not in the hard copy. So to me, I think a decent scan would be a 20 cut scan. This is what I call the Bible for the scan. And I need a hard copy of coronal cuts. Coronal is more than sufficient. And only one area I need one more cut, that is a sagittal cut. I don't believe in coronal cuts at all. In chronic rhinosinusitis, chronic rhinosinusitis, many people have the fancy of saying I'm using axial cuts for the nasolacrimal duct. All that is theory, boss, for the sphenopalatine foramen. All that is not where you're going to operate. Please understand that. So to me, coronal cuts, and if I want to see the frontal, I will use a sagittal cut. Only this I need. So very clear. Have your, of course, when you answer in the exams, maybe you might say all 3 cuts, all that. So for the postgraduates, this might not be the right teaching, but if you want to become a consultant, this is what I would like to say. So read the scan cut by cut. So do not jump from cut 1 to cut 5. So I always find that many postgraduates, when I ask them to read the scan, they come to Royal Pearl, they start saying maxillary sinusitis, frontal sinusitis. This is not what I want. CT scan is only for anatomical abnormalities, not to study the disease. Of course, it's also for to study the disease, but mostly for it's like a roadmap to surgery. So this is an important thing. So you should not jump from one cut. Don't wade into disease. So this is point number 2. Point number 3, read the scan 2 times. I always say read the scan 2 times, not 1 time. Read the scan 2 times. So above left, you have to start and then start reading and then come down. And that is only for anatomy. And then again for pathology, you have to read it the second time. So you are reading the scan 2 times, not 1 time, but 2 times. Okay. Now the point number 4. So you always look at the window setting. So window setting is very important. If you have a hard copy, many people do not know what window setting is really required for what disease. I have seen many people, the top-notch people, reading JNA scans, reading juvenile nasopharyngeal angiofibroma scans with a bone window, which is utter nonsense. So I'm going to talk about this window settings a little, and then you will understand what I'm talking about. So you cannot read a tumor with a bone window. You have to read it with a intermediate window or a soft tissue window. So this is very important. So so see the window setting, and there are 3 kinds of windows, not 2 but 3. One is called the bone window, second is called the soft tissue window, and third is called the intermediate window. So what is the bone window? Why is it called the bone window? Why is it called the soft tissue window? A bone window, so there are 2 parameters in a scan. Number 1 is called the sharpness. Second is called the smoothness. So if you ask any of your radiologists, he will tell, move from sharp to smooth. So in bone window, the sharpness index is very high. So that means you will see the small spicules of the uncinate, small spicules of the ethmoidal labyrinth. You will see the small spicules of the posterior ethmoid. All that will be seen when the sharpness is high. When you increase the smoothness, what will happen is all these will go off and you will have only the gross big bones which are defined, but you will see a lot of enhancement of the soft tissue. So this is the difference between a bone window and a soft tissue window. But what happens in an intermediate window is, so in an intermediate window, both you will have a good compromise between the bone and the soft tissue. So we also actually talked about it. We have written it in the book. For a JNA, what window would you like? I would like to have an intermediate window rather than a soft tissue window, a pure soft tissue window. If I'm given a choice, intermediate window, if not a soft tissue window, and the last would be a bone window. So these are all things you should clearly understand in your mind, what window you're reading for what disease. For example, in the AFRS, if you're having an AFRS, allergic fungal rhinosinusitis, what window do you want? If a postgraduate answers saw a bone window, then I would not be very happy, because I want an intermediate window, a soft tissue window, because I would see the double density in that. The bone window sometimes can actually mar that. So because you're going in for sharpness rather than smoothness. So this is very important. So what is the kind of a request which you are going to ask? So I have seen many people requesting CT sinuses, CT sinuses. Actually, there are good radiologists who actually know how to take CT sinuses. If you go to corporate hospitals, you are very, very super radiologists. Of course, I have a fantastic radiologist, Dr. Bavaran, who knows exactly what to give me. But there are some radiologists who may not know what to give. So that means you have to specify. So in that, I would write CT paranasal sinuses, what cut I want, coronal cut. Sometimes you can specify sagittal cut for the frontal sinus alone. So they can just give you 2 pictures of the sagittal cut alone for the frontal sinus. And I need a bone window setting. If I want chronic rhinosinusitis, CRS with polyposis, just polyposis, I want a bone window setting, because I have to see what is the drainage of the frontal. So I want, see, 1 millimeter cut, 2 millimeter cut. So basically I ask for 3 millimeter cuts. So there's something called the screening CT. A screening CT means 10 millimeter cuts. I don't recommend any screening CT for any disease for that matter. So then suppose I suspect a tumor, inverted papilloma. If I have JNA, if I have an adenoid cystic carcinoma, I would like to have an intermediate or a soft tissue window as well. So you have to specify, I need a soft tissue window separately. I have seen some scans which come from outside. There are 4 bone windows, 2 soft tissue windows, and 2 intermediate windows, 3 coronals, 4 axials, and 3 sagittals. Believe me, this is utter nonsense. There is no point in having a scan like that. When I say the patient, you have to take another scan, they get irritated. Then I say, I cannot operate. You go back. That's it, finished. Because my whole planning will depend on the scan. So with contrast or without contrast, you have to specify. Because for tumors, vascular tumors, you have to have contrast. So it depends on the disease you are requesting for. So the request should be very clear in your mind when you are writing for a request. So never operate without a scan. Of course, this was one of the controversies when we started doing FES. I remember 1990s when I used to attend conferences, people were very angry. They used to say, I can operate with an X-ray. Why do I need a CT scan? Nowadays, nobody talks about it because all that is obsolete. So nobody even sees it. I don't even take an X-ray. I have never taken an X-ray at all for years together now. So X-rays only for the exams. They will talk about, tell me the 32 things which you will see in the X-ray sinuses. Believe me, and that is all history. Please don't talk about Greek and Roman history here. We are talking about the latest what we are going to deal with. There is no rule for limited cuts as well. Okay, fine. Now we will start reading the scan, and we can have several classes. We have so many varieties of reading the scan. Okay, so the right way to start is the coronal cuts and axial sag. So basically, I just want to tell you, when you continue reading the scan, never start reading the disease. Never at any point. The wrong way of reading goes like the scan shows maxillary sinusitis, frontal mucosal thickening, etc. This is the wrong way to read the scan. So always start with anatomy. So then first cut, the second cut, the third cut, so on. Okay, now let's start reading the scan. Now this is sort of, see this one. This is the gantry view. 1, 2, 3, 4. 4, 1, 2, 3, and you have one more here down. I'm sorry, I didn't put that. So 1, 2, 3, 4. 4 into this is actually 5. So 5. So this is roughly around 19 cuts. 19 cuts you can say is 3 millimeter cuts. Of course, we have one more row. So this will have around 25 cuts. So what I mean to say is this is more than sufficient for you to read a CT scan. And you need this hard copy because it's very, very important, because every step I go to my to my console, see it, come back, operate. Of course, I have seen several surgeons operating. When they do the frontal, they never go towards the scan. This is, to me, wrong. You have to go to the scan again and again. I have seen top-notch surgeons. They go to the scan, read the scan during that step, come back. So this is the right way to operate. Put your scope down or ask your staff to hold the scope, go there, read the scan, make it something like a temple. The scan is like a temple to you. Go and see that. You can't do in the soft the soft copy. Soft copy gives only that cut. That is why I say the hard copy will give you that. Go read the scan, come back. Go read the scan, come back. So any number of times you can go and read the scan, but you cannot commit a mistake. Okay, now you should understand that previously when we started using the scans, we always put the patient in prone position with extended neck. This is how we used to take the scans, and the target will be at 90 degrees to the sinuses, and that will give you the coronal cuts. Whereas now it is not so. We put the patient in a supine position. So supine position, axial cuts reconstructed into coronal and sagittal. So this is what is being done right now. So you have different slices, slice thickness, slices of the scan, 2 slice, 4 slice, 64 slice, 128 slice. So many. And now the time required for a scan is so less. So, and it's so easy to take a scan. Now let us see now. Basically, I want you to ask for 2 things in the scan. If possible, now from today onwards, you just request your radiologist to tell these 2 important things. Dr. Radiologist, please tell me what is the anterior posterior diameter of the frontal recess. You write in your requisition. All of you in India, you start this. I have never seen this being done. They say the size of the tumor, but never they say the size of the frontal recess. So you write in the requisition, or you phone up to your radiologist and ask him, what is the size of the AP diameter of the frontal recess? That means from the nasofrontal peak till the anterior ethmoidal artery. So that means you necessarily need a sagittal cut for that. So that I will tell you if it is. So what is the most difficult part of sinus surgery? The frontal recess. So if you can deal with the frontal recess, you can deal with any part of the other sinuses. So you ask hereafter, all of you ask, please mention the size of the anteroposterior diameter of the frontal recess. Please understand that the normal size is 1.2 to 1.5 centimeters. This is the distance, normal distance. Anything less than 1 centimeter is going to put you into trouble. So anything less than 1 centimeter, anything less than 8 millimeters is going to be a difficult frontal sinus. So then you have to use various other techniques to deal with that frontal sinus. Same way, ask him also the medial lateral dimension of the frontal recess. So there are 2 dimensions of the frontal recess, the anterior posterior dimension and the medial lateral dimension. So the anterior posterior dimension means from the nasofrontal peak till the anterior ethmoidal artery. The medial lateral means from the middle turbinate till the lamina papyracea at the level of the frontal recess. Please ask them every time. If it is 6 millimeters or less, believe me, the medial lateral, it is a very difficult frontal recess to attack. You need at least 8 millimeters plus. So that means you need a 1.5 centimeter anteroposterior and more than 8 millimeters. There's 2 suctions at least to work on in the frontal recess. So this is something which I think if somebody can phone up and tell me that, yes, sir, this is what I have got from my next scan, I have written and I got it from my radiologist, I will be very, very happy that you have followed my instructions. Now, the most important thing now is to see what is a bone window, what is a soft tissue window, and what is an intermediate window. Seeing this, you should be able to say what window this is. So, for example, when I scroll the scan, you are able to see that this is. You can see that the definition of the uncinate is not very clear. You see that it's not very clear, and of course, this side itself, I have marked all that. This, I would say, would be definitely either a bone window or an intermediate window. This is a clear-cut bone window, you can see here, but this is definitely an intermediate window. So how do you read the scan? So as I told you, the first step is to read the septum. So look at the septum. The first, see, now all this while you will read the scan like a postgraduate. In the postgraduate, what you will say? You will say nasal septum, anterior arteries, dehiscent, all that you will say. But as a surgeon, you should plan reading the scan with respect to your surgical difficulties. So this is what I expect out of a surgeon reading a scan is different from a postgraduate reading a scan. Postgraduate will say type 2, Kiros, anterior artery, one OD cell, all that. But a surgeon will read it differently. So I'm going to tell you the surgeon's way. Learn the normal way from your professors. Now I'm going to talk to you about the surgeon's way of reading a scan. So what you do is the first cut which you will see is the gantry view. This is called the gantry view. And here you will see the slice thickness. How much of slice thickness? Usually they will mark the slice thickness. They will also mark the window settings. Basically, we have a very wide window setting for bone window. Please understand, you have a wide window setting, and there's something called centering. So centering is done usually at 300. So 300 is the centering. Generally 300. You can go to 340, depends on the patient. So if you want a bone window setting, then the window width is wide, centering is around 300, 350. So you should understand that this is calculated according to Hounsfield unit. You know that Hounsfield unit, Hounsfield. So you have the bone, which is the highest Hounsfield unit. So what is the Hounsfield unit of a bone? I will ask when I come as a, it is 1000. So it is 1000. And air is the least, which is minus 1000. So this is 1000 plus 1000, this is minus 1000. So anything in between, a soft tissue, a polyp, can be around 30 to 40. So you should understand that if you have a fungus, you might have maybe 70. So something like that. So plus 1000 to minus 1000, which is air, and then you have the soft tissues in between all that. So here you look at first the septum. Sorry, I'm going to take a half-minute break. Okay, look at the nasal septum. So what are you going to derive from this? Please understand that when you look at the nose, okay, you look for the height of the nose. Height of the nose. So all these you have to look for. You have to consciously look for. If you, because I operate on Koreans, I operate on Chinese patients, I operate on the Africans, I operate on Europeans. Each nose is different. When you operate on a Chinese patient, you have the nose which is flat, like this. This is a Caucasian nose, a long nose. So basically, the problem in this is that when you do the frontal, it's going to be a little difficult. So you can see that this is a very high nose. You can see that high nose. Okay. So these are all the small points you think as a surgeon. Okay. Then you see the nasal septum, whether it is deviated. So the first cut will give you an idea of whether we need to do a septal correction or not. So in this, the nasal septum is completely straight. So you don't need to do a septal correction in this case. Now, after this, you look for what is called the septal body. So I am teaching you like a surgeon, the septal body. The septal body is a body which is formed by bone and a little bit of mucosa. And you can see that the enlargement, the superior enlargement of that septum high enlargement of the septum, you might have a deviation of the bone. So the perpendicular plate of ethmoid can be deviated. And that, please understand, I have seen many people, what they do is they try to decongest. They can't decongest, keep adrenaline. Even now I saw one of the guys keeping, I said, boss, did you have a look at the scan? And he said, yes, I did. What did you look at it? So if you have a soft tissue bulge in the septal body, you can decongest it. But if you have a bony deviation, you cannot decongest it. Please understand, there is no use of decongesting a bony deviation. So you have to correct it if you want to approach the frontal. So this is what you have to look for. So look for either bony deviation in the septal body or just a mucosal thickening of the septal body, which you can decongest. At the same time, look at the frontal. Now the inferior turbinate has started appearing, then the frontal has started appearing. The right side frontal sinus is seen, the septal body is seen. Now this is where the scope is going to be. This is where the scope is going to be to approach this frontal. Okay, right. Now let us go on to the third cut. The third cut shows you. Now you can see how beautifully the okay, now you see here, you have a bone here, right? What is the bone, right? This bone is nothing but a nasofrontal peak. So this side you don't find that bone. So this is what is called the yum sign. This is called the yum sign. The yum sign means from the lamina papyracea, and then you have like this, and then from again this side it's not there, but I slightly rotate it. You will have this, and then you come like this. So you have bone continuity between lamina papyracea and perpendicular plate of ethmoid. If you have this, is otherwise called either the T sign or the yum sign, and if you have this continuity, that means this is not the frontal recess. Please understand, this is still the frontal sinus. So please understand, you don't operate inside the frontal sinus, you operate in the frontal recess. So that means this is the T sign or the M sign. This has not been published, but of course in our books we have written this is formed by me. The T sign and the M sign, and the T sign is indicative that the frontal recess has not started. But here if you look at it, there is no continuity. That means this side, the right side, the frontal recess is already started. That means from here you have to start counting the anteroposterior diameter. Of course, in the sagittal you will see it very well. So the first cell to appear is the Aganasi. Aganasi, according to Frederick Kuhn, is present in 98% of individuals. 98 to 99% of individuals have Aganasis. The bigger the Aganasi, the easier will be the frontal recess surgery. So please understand, the bigger the, what did you do? Put that off and this went off. So the bigger the Aganasi, the first cell to appear is the Aganasi. The bigger the Aganasi, the easier will be the frontal recess to approach. Now here you are able to see something here. What is this? There's the antero-inferior prolongation of the orbit. This is the nasolacrimal duct, which opens into the inferior meatus. You can see here, this always look at it and you will see that this is the nasolacrimal duct and this is the maxillary sinus. So what are the structures you are seeing here? You are seeing the frontal recess, which is started on the right side. You are able to see the nasolacrimal duct, the frontal sinus here, frontal recess here, the frontal sinus here. You can see the Aganasi on both sides and you can see the nasolacrimal duct here. So this is what I'm able to see in this particular cut. Now, what do I derive from this? What do I derive as a surgeon from this? Now let us see what I derive. Now as we go to the next cut, I go to the next cut. So after the nasolacrimal duct, what should be seen? After the nasolacrimal duct, you should see the uncinate process. As simple as that. As we go coronal, we are able to see the uncinate process. So here still on the left side, you are able to see the nasofrontal peak. Okay, so this is still a small frontal sinus, but here you can see the frontal recess very well, the Aganasi, and this is definitely the nasolacrimal duct is still here. That means the uncinate has not started, just the beginning of the uncinate. And this is the maxillary sinus, intraorbital nerve. You can see here very clearly the Aganasi cell is very big on the right side. Now let us go to the next cut. As we go here, After the nasolacrimal duct, after the nasolacrimal duct vanishes, always look for the uncinate process. Always look for the uncinate process. You know that the uncinate can get attached either to the lamina papyracea or to the skull base or to the middle turbinate. You can read that from Stamberger's textbook. And here you can see that this is going towards the lamina papyracea. Here you are not able to properly define the uncinate process. However, I would say this will go towards lamina papyracea because of the Aganasi. Why? Why do I say? Because the medial wall of the Aganasi merges with the uncinate process. So this is very important. So this uncinate goes and merges with the medial wall of the Aganasi and it goes here. That means the frontal drainage is a medial drainage. So this is very important. So PU means uncinate process. The middle turbinate, you can see that's the sagittal attachment of the middle turbinate. This is the frontal sinus. See here, you can see here, the first cut. There is no frontal sinus at all here. Did you see that? There's aplasia of the frontal sinus on the left side. The right side only you have the frontal. That's why the frontal recess is wide on the side. There's still a very, very small frontal sinus. So actually it is almost aplastic, a very small frontal sinus. Hypoplasia you can call. So here we are going towards the next cut. You are able to see the uncinate process, PU, uncinate process. After the uncinate process, what will you see? Very simple. It's the bulla. After the uncinate, you will see the bulla. So you can see what you will see in the next cut. According to you now, see, when you're looking for the uncinate process here, what do you look for? When you're looking for the uncinate process, I will see, why should I look at the uncinate process? I have to look for it for the frontal or I have to look for it at the maxillary sinus. So you are looking for the infundibulum. This is the infundibulum. This is the hiatus similaris inferior. The infundibulum is a 3D structure. So here, when I go here, I am looking at, see that's the uncinate process. This is the infundibulum. So you can see that I can easily approach the maxillary sinus. When I backbite this, I will find natural ostium here. So beautifully seen. See that. And this is, of course, the bulla. After the uncinate, this is going to be the bulla. See in this side and that side. Now let us compare now here. See, this is the infundibulum here. Okay, so infundibulum is slightly more anterior. If there is no tilt, it's slightly more anterior compared to the left side. See that? See that? Can you see the difference? This is the horizontal part. I cut the horizontal part slightly posterior, get the infundibulum here. When you cut it here, it is almost here. You can see that very clearly. So this side is blocked also. There is some disease here. And the frontal also is diseased here. Okay, fine. Now, I am now going on to seeing the bulla. You can see the bulla here, the bulla. When you look at the bulla, don't look only for the bulla. Always look for the suprabullar area. So this is the suprabullar recess, which is actually, and that bone is the anterior fovea. So you have, this is the medial lamella and that's the lateral lamella. This is the medial lamella of the cribriform plate and that's the lateral lamella of the cribriform plate. And at the junction of the medial lamella and the lateral lamella, the middle turbinate originates. You can see here. This is the sagittal attachment and this is actually the medial lamella. That's the lateral lamella and here is the frontal bone. So here we have the suprabullar area. So this is always look for the bulla, and once you look for the bulla, look for the suprabullar area. And if you have you might have a cell, the suprabullar cell, or you might just have a space, a recess, suprabullar recess. But please understand that the roof is formed by the anterior fovea. This is the anterior fovea. This whole thing is the anterior fovea. And this area is the most dangerous for entry into the intracranial cavity. This is very important. As a surgeon, you should be very careful. And that is what after the bulla, what you will have. So when I go to the next cut, see, beautiful, beautiful. You can see that very beautifully. So after the bulla gets attached anteriorly. After the anterior attachment of the bulla only, you will have the anterior ethmoidal artery. So you can see the anterior ethmoidal artery. So you have to form a sequence in your mind. So the anterior ethmoidal artery comes between the superior oblique and the medial rectus. The superior oblique muscle and the medial rectus, it penetrates. It's a branch of the ophthalmic artery, the anterior ethmoidal artery. You can see a nipple. It's called the Kennedy's nipple, a prolongation of the supromedial aspect. A prolongation of the inferior-medial aspect is the nasolacrimal duct. A prolongation of the superior-medial aspect is the anterior ethmoidal artery. Now you have to look for supraorbital pneumatization. If there is a supraorbital pneumatization, the anterior ethmoidal artery is dehiscent. Please understand that. You should understand that this will be dehiscent, and you can see that the bulla, you can see very clearly getting attached right till that skull base there. This is the skull base attachment, and you can see that the anterior ethmoidal artery and the medial rectus muscle is here. And of course, this is the middle turbinate, the inferior turbinate, the septum. Septum doesn't need any surgery for this case. Now, as we go behind, so look for the anterior ethmoidal artery. At the level of the anterior ethmoidal artery, always you should look for the Quiros classification. So look for the skull base, whether it is deep skull base. So you have to measure the distance between the medial lamella and the lateral lamella. So you know that it's from 1 to 3 and 4 to 7 and above 7, it's type 3 skull base. But for a beginner, consider all skull bases as type 3 skull base and operate. So, but this is maybe a type 1, type 2 skull base. It's pretty simple, but then be very careful. Don't direct your instrument medially and superiorly at the level of the anterior ethmoidal artery. This is very important. Now, this is one area where you can see a supraorbital pneumatization, and you can see the anterior ethmoidal artery going like this. And if you have like this, don't use a punch. Don't use a punch, and you will cut or you don't pull it with a Blecker sleeve. This artery will retract inside the orbit and produce intraorbital hemorrhage. So this is very important. So next step is look for the basal lamella. Once you finish off the bulla, you finish off the anterior ethmoidal artery, what next will come? The basal lamella. Once you have the basal lamella, you will have the superior turbinate, and this is the beginning of the posterior ethmoids. The cells will become more rectangular, and of course you will have the cells which are actually more rectangular. You can see that very clearly, and this is the view, the superior turbinate, the middle turbinate. That's a horizontal attachment. So this is wrongly marked, inferior orbital fissure, wrongly marked. Of course, then you can see here. Then this is the sphenoid sinus, the sphenoethmoidal recess. You can see that's the right side dominant sphenoid and left side, which is a smaller sphenoid. Look for Onodi cells here, of course, and then the Onodi cell can be here. The anterior clinoid is here. The medial pterygoid plate, lateral pterygoid plate, the median canal, the foramen rotunda. All that you have to look for as you read this scan. Now let us go on to see about the frontal cells. This is something which is very tricky, and let me tell you about. I'll tell you. No problem. Now I'm going to show you in detail about the frontal cells, because this is very important. Many people have not understood this in a big way. So I'm going to teach you. If you find a cell inside the middle turbinate, it is the concha bullosa. You know that, right? So a concha bullosa can be of many varieties. You can have a lamellar concha. So this concha bullosa is a cell which pneumatizes. It usually pneumatizes either from the ethmoids, the anterior ethmoids, the posterior ethmoids, or the frontal. Usually it is from the posterior ethmoid. So if it is from the posterior ethmoid, it is called, anybody? It's called the interlaminary cell of Grunwald. So it's called the interlaminary cell of Grunwald. And see, the first cell to appear is the Aganasi. The Aganasi cell is always below the nasofrontal beak. Please understand, the Aganasi is always below the nasofrontal beak. This is the NFP. See, this is the T sign or the M sign. This is the M sign. Okay. Now, as we go behind, you look for the cell. See here. This is the nasofrontal beak. Okay. Now, this is the Aganasi, and you are finding one cell above the Aganasi. If you have what is called a bipartite Aganasi, that is cut in between. So this is a type 1 Kuhn type cell. So this is an So basically the cells can be divided into anterior group and a posterior group. So if you are asked in the exam, what are the frontal cells? You have to say frontal cells are classified according to the Kuhn's classification. There is also P.J. Ormond's classification. You can follow either one, but then I prefer Kuhn's classification here because you can see that this is a bipartite. So any single cell above the Aganasi, below the nasofrontal peak, is a type 1 cell. Okay, this is anterior group of cells. So second is when I go here, you see that, of course, there are 2 cells here above the Aganasi. This is a type 2 cell. The interfrontal cell also is here. So a type 2 cell. I will show you some examples now. Now, this cell, see this cell. This cell is up. This is a nasofrontal peak at this level, extending above the nasofrontal peak. But there is one classification by P.J. Ormond which says that if the height is more than 50% of the vertical height of the frontal, then it is a type 4. Sorry to tell you, I don't agree with it. I have my own views, right? I don't agree with that. This one at all. By definition, a posterior group of cells should always have the posterior wall of the cell should be formed by the skull base. So if the height doesn't matter to me, so I will not recommend that to any person. I mean, at least a surgeon. So here you have an interfrontal cell. You have a cell above the nasofrontal peak going inside the frontal sinus, and that's a type 3 cell on both sides. So that means when you open here, you're opening the Aganasi, that's a type 1 cell. I open the type 1 cell. When I open here, what will happen? I'll be seeing a big cavity here, and I might think this is the frontal sinus. So unless you read this scan, imagine here, you will see one big cavity here. You will think it's a frontal, but you will not open the real frontal sinus. So that means you have to go medial to it, posterior to it, break this cell and open up the frontal sinus. So that is the surgical importance. When you look at a type 3 cell, be very careful. You might actually miss the frontal sinus. And this is typically a type 4 cell where you have a satellite cell inside the frontal sinus, but there is no typical type 4 cell at all. It is all extensions of a posterior group of cell. So now let us see here. Now let us read this scan. See here, this is the frontal sinus. So when I look at it, what will I look? I'll look for the septum. You see here, the perpendicular plate of ethmoid is bent towards the left side. So this frontal is going to be difficult for me because then you see here now. I will see whether it is bony or cartilaginous. See here, this is bony. How can I ever decongest this side, boss? I have to do a light cutting here, or else I cannot do this frontal recess at all if it's disease. So this is the first thing I would like to look for in the scan. This is a typical bone window scan. And then when I go back, I'm going to show you this one again. You see that clearly the septal body. Here you can decongest. Here I cannot. I have to do a limited septal correction here. Of course, the anterior part of the septum also is deviated. Now let us go behind. You are able to see that's a frontal. You have seen the interfrontal cell. Interfrontal cells generally drain into one frontal recess. So you can see that very clearly. The left side, you have a deviation. And you can now go back and see that's still the T sign. You can see the T sign. So if that is a T sign, this is the Aganasi. And this is a small agar here. And that's the interfrontal cell. So you have to go back and see where it is draining into, the interfrontal cell. Now you can see here, this is the Aganasi. Middle turbinate has started appearing. So when the middle turbinate has started appearing, what you will look at, this is nasofrontal. This is a nasolacrimal duct. You can see nasolacrimal duct. At this area, don't look for the uncinate process. You can't look for the uncinate process at the level of the nasolacrimal duct. Many people think this is the uncinate process. No, how can you get the uncinate process at the level of the nasolacrimal duct? So here I go behind. You can see that's the Aganasi, which is the first cell to appear. Small Aganasi here. The middle turbinate has just started appearing here. And as you go behind, see this. This is the frontal recess, the loss of the T sign. But here you can see that this is the Aganasi. So this is the medial drainage. So any drainage medial to the Aganasi, which is actually the uncinate process. So medial to the uncinate process will be a medial drainage. And this is actually a small spicule of bone. And how do you approach the spicule? You could just go behind and see. So if you go one cut behind, then you can see that the uncinate is going here. So what does it mean? If I remove this uncinate, this drainage will be lateral drainage. So you have a lateral drainage on the left side and a medial drainage on the left side. Imagine that you're going to approach like this. That is, I go here, I approach like this. What you will do? You will enter into the skull base. So you should read the scan very clearly. See how beautiful. This is lateral. Lateral drainage means lateral to the uncinate process. So here you have a lateral drainage, here you have a medial drainage. So you the totally different scenario. Here you have to push the uncinate process laterally. Here you have to push the uncinate process medially. So this is very, very important, my dear friends. So this is the uncinate process. So important to read the scans properly. Then you go for the frontal recess. Of course, the frontal recess is quite wide. The crista galli also is pneumatized a little bit. I'm looking at the uncinate process here. You can see the uncinate process going towards the lamina papracia. And you see here, this is the infundibulum. This is the infundibulum. You can see the infundibulum very, very clearly. You can see the infundibulum here. And then that's the bulla. You can see the bulla. Sometimes you will have what is called the torus lateralis. Torus lateralis means a non-pneumatized bulla. And this is the horizontal. So, as an examiner, I'll ask you, in how many cuts uncinate process will be seen? What will be your answer, man? So, people say in one cut, in two cuts. Believe me, it's not so. The uncinate process has got two parts. One is the sagittal part, second is the horizontal part. Horizontal part can extend right till the level of the palatine bone. Palatine bone is at what level? It is behind the bulla. So that means you can have it in at least 6 cuts. So this is all the horizontal part of the uncinate process. So you can have it from 1 cut to 6 cuts, you can have the uncinate. The horizontal part of the uncinate is very deceptive. You should see how the horizontal process has to be dealt with before you enter into the infundibulum. Please understand that. So that is very important. And once you see here, this is the skull base here, but don't read the skull base here because this is the area we will not be enjoying. But here is the anterior ethmoidal artery. See, this is the anterior ethmoidal artery, and this is a supraorbital pneumatization. This skull base is a very low skull base. So here, if you want to, if you have disease here, imagine you might get a camouflage. You might actually try to enter here, and this is the most vulnerable part of the skull base. You might enter here and cause a CSF rhinorrhea. So be very careful when you deal with it. So that's the bulla. You can see here very clearly the soft tissues are very beautifully seen. You can see that very clearly. Now it's almost like an anterior ethmoidal artery is very clear. There's a dehiscent. It's dehiscent. It is Kiros type 2 classification because it is around 7 millimeters, something like 7 millimeters here. And then you can see that this is the middle turbinate going towards the sagittal attachment. This is you can see that now the mid. See this beautiful. See the beauty of the scan. You can see the basal lamella. See how the basal lamella getting attached to the lamina papracia. The basal lamella is the coronal attachment of the middle turbinate towards the lamina papracia. Now after the basal lamella, you have to look for the posterior ethmoids. So in the posterior ethmoid, look for the skull base of the posterior ethmoids, of course, and then when you go back, you have to look for the onodi. Any horizontal partition in the sphenoid sinus is taken as an onodi until otherwise proved. This is the posterior ethmoid still, and you go back, that's the sphenoid sinus. In the sphenoid sinus, what do you look for? You look for dehiscences here in the carotid artery. This is the anterior clinoid process. You see 2 canals. One is the VD. So remember that V is after the letter F, right? You remember like this. Many people used to say this VDM canal, this foramen rotundum. So V is the last in ABCD. So the last letter will come down, and F will come up. So you remember foramen rotundum, VDM canal. So of course the experience don't need anything. Now you can see here that there is dehiscence here. So there is some tumor in the region of the sella. So I mean, of course, you don't have to look at it right now. So this is how. Okay. Now let us now read some other scans. I'm going to show you some scans. This one. Huh? Yes. We'll do all the 3 cuts, right? One second. Let us finish this. Now let us read this scan. It's just a coronal cut. Are you able to see Dr. Dinesh?
Yes, sir, we can see.
Okay. Now let us start reading the scan. You can see here. What do you see here? The nasal septum. Always you train your eyes, see the nasal septum. As we go behind, see that there is a little deviation of the septum, high septal deviation. So what you will think, I am going to have difficulty in this approaching this frontal recess. This is very important. As you read the scan, you should start thinking. Now, see that deviation, mild deviation of the bone here. So if that is going to be a problem, then I can't see the axilla of the middle meatus. So that's going to be a problem. See clearly the deviation here. So that means I have to do a limited septal correction if, to approach the frontal if I have a problem. Now, let us look at the frontal. Frontal is very well pneumatized on both sides. I can see that very, very clearly. And you can see that's the Aganasi. This is the first cell, the Aganasi. Can you see that very clearly? Very, very nicely seen. And what cell is this? A cell above the nasofrontal beak. A cell above the nasofrontal beak inside the frontal recess is nothing but a type 3 cell. So this anterior group of cell, a type 3 cell. So very, very nicely seen. Very beautiful. You have to follow that cell. You see here. Don't see that in a single cut. You just try to follow that cell behind and you can see that that is the cell. Very nicely seen. It is actually see how that cell is draining. See just this cell alone. See that cell. You can see that cell is coming there like that and it's draining here. So the drainage of that cell is actually here, medially. So that means how do you approach this frontal? Let us see now again. Now I will be doing, I'll concentrate only on the right side. So I'll be, that's the uncinate process. First of all, I would like to do a limited septal correction on the right side to make this straight. And then what I will do, see, I've still not got the middle turbinate. I will look at the middle, see, that's the middle turbinate. See, this is the middle turbinate here. Then what I will do is I'll remove the uncinate process. Where is the uncinate process here? So this is the nasolacrimal duct, right? This is the nasolacrimal duct. Can you see? This is the nasolacrimal duct. After the nasolacrimal duct is the uncinate process, right? Next will be the, see, that's the uncinate process. Can you see here? The uncinate process going and getting towards the middle turbinate. So what will happen? The frontal recess drainage. It will be a lateral drainage. You get my point or not? So very clear. Your planning should be, see, first of all, you see the nasolacrimal duct here, nasolacrimal duct. Immediately after you go posterior, you see the, look for the uncinate process, see the uncinate process here. Where you trace the uncinate process, the middle turbinate, going towards the middle turbinate. So once you see the uncinate, you just remove this uncinate here like this till here, automatically you will see the drainage here. As simple as this. So you should, so well, let us go for the left frontal recess. Now this is the nasolacrimal duct. Can you see here the nasolacrimal duct here, left side frontal recess. Now this is the nasolacrimal duct. There's a lot of disease here. The little neoosteogenesis. Can you see a neoosteogenesis here? Neoosteogenesis is a dangerous sign because you cannot open up the frontal at this area at all. So let us go slightly behind. There's a little disease. Now you can see there's a little disease. Now where is this uncinate going? You can see that now still the nasolacrimal duct is there on the left side. And as we finish off the nasolacrimal duct, you can see that's the uncinate process. And this uncinate is, I am not able to follow it properly. And I will go here. And once I see that, you can see that this is the uncinate process and you can see how it's going here. So sometimes you might have a forking of the uncinate. So this can be one limb, there can be another limb here also. If there is a forking, then it will still be a medial drainage. If there is a forking, it still can be a medial drainage. So you have to follow it behind to see if, see, there is neoosteogenesis, a little neoosteogenesis, and that is, see, you're seeing the neoosteogenesis along with, see that, this is neoosteogenesis here. And you can see that the uncinate is going like this and like this. There is a little forking. So I most probably, and another thing I told you is you see the frontal recess here, okay? The frontal recess. So I'm going, see, this is the nasofrontal beak. Okay, now from here, this is the frontal recess, right? Okay, from here you calculate the anteroposterior diameter. Of course, if you have all the three cuts, it's fine. You see, where is the anterior ethmoidal artery? This is the anterior ethmoidal artery. Can you see? Till here is the frontal recess. So you have around 1.5 centimeters. It's an easy frontal. You can see it's an easy frontal to operate. So these are things you should look for. So read, see, either you read cut by cut or you read sinus by sinus. I strongly recommend as a surgeon to read sinus by sinus. First of all, you finish off the frontal sinus. What is the difficulty I will encounter? Right side will be easier. Left side will be a little difficult because you have neoosteogenesis and you have disease and there's a forking of the uncinate. So I finished the frontal sinus. The next will be the Middle terminate, you have a concha bullosa. So you will also deal with the concha bullosa on the left side. So you will have a little paradoxical terminate here. And then I will look for the maxillary sinus. Now, what should I look for the maxillary sinus? I have to look for the uncinate process. So this is the uncinate process. You have to look whether it's horizontal or it is vertical. If it is vertical, it is easy. If it is horizontal, it means there is a hypoplasia of the maxillary sinus. This is not hypoplastic. You can see that's the uncinate process very clearly. And here, if I take off the uncinate, the infundibulum is very wide. So this is an easy maxillary sinus. So you can look for the maxillary sinus. How do we approach the maxillary? So I finished off the frontal. I finish off the maxillary sinus. Now you have to look for the bulla. Now this is the horizontal part, the bulla. This is the bulla, the supraorbital area. There is the fovea. So you can see that very clearly. You can see that fovea. The problem here is the anterior ethmoidal artery is dehiscent. You can see supraorbital pneumatization. So you should be very careful at this area. Look for dehiscences of the lamina also. As you see, you look for dehiscences in the lamina and also dehiscences in the skull base. Now, what kind of skull base is this? Where do you look for it? Here is where I will look for it. See the anterior ethmoidal artery? At that level, I will look for the skull base. It's a type 1 skull base. Not maybe type 1, type 2, but this is a type 1 skull base for all my practical purposes. And so it's very easy. Concha bullosa is also diseased here. Septal deviation is here. And as I go, the next I will look for is the posterior ethmoid. You see, this is a posterior ethmoid, very wide posterior ethmoid. The skull base is very, very thick here. There is no rarefaction. So I can easily take off all the cells in the posterior ethmoids. So here, as I go behind all these posterior ethmoids, and that's the sphenoid sinus, you have onode cell. You can see here, that's a onode cell here. So the bigger the onode, the more difficult will be the sphenoid sinus. Please understand. The bigger the agonasi, the more simple is the frontal sinus. The bigger the onode, the more difficult will be the sphenoid sinus. So here we are. So now, having read this, again you will go back again, read again. What are the sinuses I have to open? Don't open a normal sinus. You don't have to do a full house stress for everything. So here I will open up the infundibulum. I will open up the infundibulum on both sides. I will do a concha bullosa resection. I will remove the bulla. I will attack the frontal recess on the left side very clearly. Apart from that, the maxilla, the left frontal, and the sphenoid. See here. So to operate on the sphenoid, I have to necessarily go through the posterior ethmoid to open it. So I would go for the bulla. I will go for the posterior ethmoid. I wouldn't deal with the skull base because I mean, as a junior, I wouldn't do that because the anterior ethmoidal artery is dehiscent. I would stay down and I will open up the sphenoid sinus and come out. So this is how I will plan my surgery in this case. Now let us go to the next scan. Yeah, now I will just this one. Same case. Okay, now this is the soft tissue window of the same case. You can see here. You see most of the detailing of the uncinate is lost now. See, I told you. This is the softness of the scan. That is the sharpness. This is the softness of it. You can see the thick bones, but you can't see the thin bones of the uncinate. See where the uncinate is getting attached. If you get a scan like this, how will you plan your surgery, boss? So it is not possible whether this uncinate is going here. You can't. Same case, soft tissue window, absolutely nothing. But this is useful for fungal sinusitis because you will see double density. So this is an example to show you. If you get a scan like this, a hard copy, it's of no use to plan your surgery. Now, again, I'm going to tell you another case. Now, let us see. Now, let us see this case. Now, I'm going to plan this case. How am I going to plan this case? Now, septum. First, look at the septum. Do I need an anterior septal correction? No, I don't need. So, till here, you can see, oh my God, this is something like pneumosinus dilatans, huge frontal. There was a study saying the size of the frontal will compare to the IQ. And one study said, bigger the frontal sinus, the lesser the IQ. But honestly, I have a big frontal sinus. So, I don't know how my IQ is. Anyway, that's the frontal, which is completely... Don't look for disease. Immediately don't say there's disease in the frontal sinus. Look only for anatomy. So here is the agonasi. So this is a little neoosteogenesis. You can see here. This is a rarefied bone. So all that is because of chronic infection. You can see that's the agonasi. And you can see here a small cell here. What is this? This is an interfrontal cell. You can see there's a septal body, huge septal body. So I will keep a lot of decongestants here, decongest the septal body. Now I'm looking at like a surgeon. Okay. Now this is the Aganasi. So next what I will look for, I look for the nasolacrimal duct. So the nasolacrimal duct is what I will look for. So where is the nasolacrimal duct? Anybody? So this is the nasolacrimal duct. You can see here, anteroinferior prolongation of the orbit. And then you will, next cut itself, you look for the Ansonet process, right? So before that, I'll see if there are any cells. So this is the interfrontal cell, which is draining into the right frontal sinus, the middle turbinate. And you can see here that as I go behind, I will look for the nasolacrimal duct. This is the nasolacrimal duct. From behind, I will look for the Ansonet process. Looks like this Ansonet is going towards the lamina papyracea. You can see here that's the Ansonet process very clearly going towards. Can you all appreciate it? So that's a medial drainage, a huge wide front recess. You ask for this parameter from your radiologist, this and the anteropace to posterior diameter, and you can plan your frontal recess surgery. This is a simple frontal. Of course, the next step I will look for is the maxilla. Maxilla is a very, very easy maxilla because you have a wide infundibulum on both sides. I have to plan. The maxilla seems to be quite easy. And of course, there's a crista galli, a little osteoporotic, that is. And then I will look for the anterethmoidal artery. The next is anterethmoidal artery. See here, the anterethmoidal artery is dehiscent on the left side and on the right side, the supraorbital pneumatization. And you can see a lot of pathology. Don't look at the pathology, but look only for the anatomy. And when you look for the anterethmoidal artery, always look for the skull base. This is type 1 skull base. So you can easily deal with the type 1 skull base. Then you go behind, that's the basal lamella. Can you see here? This is going towards the lamina papyracea. This is actually a pneumatization above the orbit. You can see the lesser wing of sphenoid going up. You can see here that this is a very, very beautiful posterior ethmoid. As we go there, you can see that this is the sphenoid sinus. Anterior clinoid is pneumatized there, and the sphenoid sinus is very wide. So the sphenoid sinus I don't have to open. Maybe there's a little, because I might open and do a full house fest. Basically, that is done for assisting my post-operative care of how to, irrigate the nose and things like that. Of course, when you want to look at the skull base, you have to look for the foramen ovale, which is here. That's the foramen ovale. And now this is okay, fine. So having read this scan, now let me look at the soft tissue window of the same whether we'll get the same kind of detailing. So see here, see the soft tissue window. Can you get any details? I can't get any details. You don't know where the Ansonet is. So the same thing I'm showing you in soft tissue window and bone window. See, the setting is so important, so important. Here you can't see anything. The concha bullosa is seen, but apart from that, I can't find out anything there. And of course, I will look for double density alone in this case. There's no double density. And please remember, if you have air pockets like this, air pockets, then it is usually sinusitis. So air pockets in any sinuses mean anaerobic organisms or sinusitis. So I can see air pockets, bubbles, not even bubbles. It looks like sinusitis. So just to compare these two, you can see that this is of no use. Now I'm going to put this window and show you what window is this. You can see the small spicules. It is a bone window, very, very clearly seen. And then I'm going to play the next one. See, that's the bone window. And this is again beautiful bone window showing small spicules of bone. And this is soft tissue window. You can see here the soft tissue window. And you see this, it's called the smooth. I told you there's something called the 3D smoothness. There is something called the 3D smoothness. You have to consult your radiologist. He will give you all the data available. And now let us go on. Yeah, now you see here, this is one case I did yesterday. Very beautiful case. I want to bring to your notice. See, I told you there's a problem I faced. Even an experienced person like me can face a problem. You see here, read this frontal. The frontal is pneumatized, well pneumatized, but you're seeing a cell here. Can you see a cell here? Okay, this cell, the posterior wall is formed by the skull base. So this is actually a type 4. Type 4 means it's a cell arising from posterior. Okay, fine. As we go, you see the new osteogenesis. See the new osteogenesis here. Okay, as we go here, you're seeing one cell here, type 4 cell on the side, and you can see one cell here, there's a small cell here. You have a type 3 cell, a type 4 cell, and lot of new osteogenesis. Now, as I go here, see here, bilateral type 3 cell, huge new osteogenesis. And then when you compare this side, see the orbit here, see the orbit and see the middle turbinate. This is the middle turbinate here, this is the middle turbinate. The distance is so less. There was a very small distance with crowded cells. You had type 3, you have type 4 on both sides. You see here, this is one cell here, the Aganazi, then 2 cells above. So you have type 2, you have a type 3, you have a type 4. So all kinds of cells you're seeing. You put this again where if you have recorded this, you can see how difficult this frontal is. So you have to know how to open up this. Of course, there will be a separate session on the frontal. I'll be dealing with that. Apart from that, as we go behind, you can see that. So all of this were easy. The polyposis part was very easy, but the frontal was a little tough because of the presence of numerous cells there. Apart from that, the anterior ethmoidal artery is dehiscent. You can see the anterior ethmoidal artery. So the anteroposterior distance was the only thing which could help me. But what happened in this case was, you can see that this cell here, this cell, which is the posterior group of cell, had a very thick wall because of this new osteogenesis. So to break this wall, we had to use articulated punch. So you have to use articulated punches for breaking some difficult cell walls. Okay, so having said that, you can see this is one of the difficult cases. You can see how many cells here. See the onodi, crowding of the posterior ethmoid. See the crowding of the posterior ethmoid. So many posterior ethmoid cells and the sphenoid cells. So this is actually a difficult. So in a CRS itself, you might have difficult situations. Well, I want to bring to your notice another important development in the reading the scans. That is the DICOM software. So you can actually plan your surgery with this. Okay. Now, this is the DICOM software. I think you can download it and you can actually see all the 3 cuts. To me, it doesn't carry much meaning, but then, of course, you can actually read the scans. Can you? Yeah. So if you read that, if you have this, what information does it give? Nothing. But this gives me an information. So you can see this distance from the nasolacrimal duct till the end. So I'm going to show you. Can you? Yeah, I'll do. Yeah. So here, that's the frontal recess. That's the frontal recess. Keep that cursor down. Yeah. So you can see. Yeah. Stop. Here you can measure in the wait. Here you can measure the anteroposterior diameter of the frontal. This is very important. So it's a very wide frontal, around 1.5. So this measurement I want you to ask your radiologist. It is available for free in Apple Store. So you can actually see. You can even change the window setting. So you can change the window setting. You can move. You can play around with this. So it's very useful. So this is the nasolacrimal duct. This is the nasolacrimal duct. And behind it, can you move it slightly? Exposure is seen. This is a good exposure. Yeah. Yeah, sharpness, smoothness. You can see the value also. You can see here value -35. All that you can see, and you can calculate the the Hounsfield unit of each. And you can see how basically this I recommend for most of my, but the thing is I also need a hard copy. This is something which we use, but then we also plan it with a hard copy because I keep on seeing all the scans. I will plan to see the anterior ethmoidal artery is dehiscent here. I always plan the surgery by going there and seeing every cut. I plan that with a 3D in every exposure. So that's actually, you can see that very clearly that you can actually move the scans. So this is something which is seen the navigation also. Yeah, you can just take one cut, reconstruct. So this is how I read a scan, and I think the next session is where I'm going to deal with surgical part of endoscopic sinus surgery. This is the next week. So with this, I think you have had an idea of how to read scans. Now we can take questions. Dr. Dinesh, are you there?
Sir, Harsha, yes, sir.
Harsha is there? Okay, great. So first of all, let me thank Dr. Harsha, who is in charge of Harsha Foundation. And now he started his very high-tech clinic in Hyderabad with all the 4K systems and things like that. I'm so proud of Dr. Harsha. God bless you, Dr. Harsha. We'll be inaugurating that very shortly with a bang. I'm sure that you will do very well. And you're propagating academics to the whole world. God bless you.
Thank you, sir.
Now we can take questions regarding the scans. If there are any, then I think Dr. Agilasamy is there, very, very experienced endoscopic sinus surgeon. We can ask him to give some comments before questions. Dr. Agilasamy, can you unmute yourself? I saw you.
Janaki?
Yeah, Dr. Agilasamy, thank you very much. I think we are going back to our first year days when we started doing endoscopy. But now, you know, we need to start with basics also. That's why I'm doing this. Agilasamy, you can...
Excellent. I was glued to the whole session. Excellent. One thing, you didn't show the soft tissue cuts. You could have shown some fungal pathology, something.
No, the pathology and surgical aspects we are planning for the next.
That's good. That's good. Otherwise, excellent. Thank you, Janaki.
Thank you.
Even though I am 50 years and I am your colleague, still I loved and enjoyed the whole show as a postgraduate.
Thank you, Agilasamy. Will, thank you for your presence, Dr. Agilasamy.
One more thing, Harsha, please share the link in the various links. People who have missed, they can watch it again.
Okay, sir, I will do so.
Please, thank you.
Dr. Agilasamy is a fantastic surgeon. Something unique about him is he does endoscopic sinus surgery under local anesthesia. We'll have a talk from him in subsequent weeks as to what is his trick to do it under local. If you're okay, Dr. Agilasamy, we'll have a talk by you.
Sure, Janaki. Yeah. Most of 98% I work with the local only. Yeah, there are a lot of tricks. It's you have to learn the art, master the art, but a lot of tricks and everything. Definitely, I will teach everybody. Thank you.
Thank you, Agilasamy. Do we have any questions, Dr. Harsha?
Sir, Dr. Fan, he's asking, please explain El Toro sign in.
No, you ask him to talk because it's better we make them interact, you know.
Sir, okay, sir.
Yeah, you can raise your hand and unmute yourself and talk, my dear friends. So that will be making you interactive with me. So this is going to be a series of lectures. We also have grand rounds by my classmate, I call him Encyclopedia of ENT, Professor Anthony from College. And he's going to do grand rounds for the exam-going PGs. We've started this because during the exams, it will be very useful for you. And we'll bring in a lot of good speakers like Professor Anthony, Dr. Agilasamy. Now, Dr. Sriharsha, you want to share your screen?
Sir, I just wanted to put that flyer, sir.
Yeah, please put the flyer.
So, Dr. Fan, can you unmute, sir?
Yeah, Dr. Fan, please. A lot of people raising their hand. Dr. Z Xiang Yo. I think he's from Vietnam. Dr. Z, you can talk.
Good afternoon, Dr. JANAKIRAM. Just wanted to ask you, have you encountered frequently pneumatized crystal line? And what do you do with it if the patient is asymptomatic?
See, pneumatization of any sinus without symptoms doesn't carry anything because we don't treat scans, we treat the patient. And I am yet to see a patient having a pneumatized crista galli producing a problem like headache. Of course, I've seen patients having fungal sinusitis where crista galli also has got fungus, or mucoceles of the crista galli, we opened it. Usually crista galli opens into one of the frontal recesses. So we can approach through that and actually drain it. So, but headache just due to pneumatization is, I've never seen. So pneumatization doesn't mean that you have to operate. We don't treat scans, we treat the patient and we treat the symptoms. Yeah, I hope I answered your question. 1 plus nod, please carry on. Unmute yourself, my dear friend.
Hello, good morning, sir.
Morning.
Sir, I want to ask that you have mentioned in the beginning of the scan that we have to do a septoplasty if there is a bony deviation. Sir, in case of bony deviation,
Come again. What is your question?
Sir, in the while reading the scan, you have mentioned that we have to do a septoplasty if you have a bony deviation, a high bony deviation.
Yes, yes, yes. The indication is if you are not able to see the axilla of the middle meatus due to any septal body, whether it's cartilaginous or bony, it is mandatory that if you want to do a frontal recess surgery, you have to correct it. If you're not doing a frontal recess surgery and the frontal is completely normal and there is a cartilaginous or bony deviation, you're just having maxillary sinus disease, then you don't have to do a septal correction. But if you're doing a frontal, at least for post-operative care, at least you have to visualize it post-operatively, or else you can just manage by decongestion. But after you remove the pack, it will start bulging and it will push the middle turbinate laterally and it will close the frontal recess. So at least for post-operative surgical surveillance and for the steroids to reach, you have to do a limited resection. Yeah,
Sir, if
Dr.
we are planning for an endoscopic DCR, do we have to correct that immediate deviation as well?
See, basically, there are two aspects. One is visualization, second is post-operative care. If you feel that you can just visualize it and then carry on, and you feel that the post-operative care can be difficult, sometimes it will cause edema, synechiae later, then I think it is, even if you have the slightest doubt, do it off. There's nothing lost. It takes hardly 5-10 minutes. But then you're going to, the whole, life, this patient is going to be rid of disease. But if you see that 5 minutes, the problem that is to correct it, then the post-operative care will be difficult.
Thank you, sir. Thank you so much.
Yeah. Dr. Ailasami, you raised your hand.
Janaki, one question. What is Parsons window? What is Parsons window?
You can't ask questions, my dear friend. You can only give comments or answer. Don't ask any questions.
Because we were talking about MMA. What is Parsons window? Have you heard of it? Parsons window.
Parsons window, I've heard of it, but I don't know.
Okay, leave it. Because in a workshop when I was operating, somebody raised and asked me what is Parsons window. I remembered only Parsons Ridge, what you taught me.
Yeah, Parsons Ridge I know, Caroline's window I know, but everybody nowadays have started having fancy names, so I really can't follow everything. Caroline's window, you know who is Caroline? Caroline was the resident of Professor Harvey, and he is named after his resident. Like that, people have started naming everything. Harzella cell. That's also there. I met Professor Harzella. Very nice.
Harzella. Posterior model cell.
Yeah, all that,
Supramaxillary.
Yes. So many things are there.
Fancy. But somebody from the audience told me that Parsons window is just when you do with the backbiting and do an lower 1/3 that middle metal antrostomy, removing only the lower 1/3 of the uncinate, you make a window. That is Parsons window, somebody told. But I haven't read it anywhere. Thank you.
It's there. I just now my son is showing on the net. It is there.
Okay. Thank you.
Yeah.
Bye.
Dr. Abba.
Yes, sir. Hello, sir.
Hi.
Yeah, how can we identify the accessory ostium And second is can you again explain the three parts of attachment of middle meatus in the CT?
Middle turbinate or middle meatus?
Turbinate, sorry.
Okay. So, shall I go back to the CT now? 1 second. Put the CT scan. Okay. Now, yeah, this is fine. Now you see, axillary ostium, when you look into the middle meatus, if you see any ostium, it's an axillary ostium. Please understand that. A natural ostium will never be seen. It will be hidden by the horizontal part of the uncinate process. So that is the first thing. Second is, if you see it exactly in the sagittal plane, it is an axillary ostium. If it is completely rounded, it is an axillary ostium. So the natural ostium is obliquely oriented. It is not sagittally oriented. It is hidden, and it is oval in shape. So this is the difference between axillary and natural ostium. Having said that, now your second question, answer your second question. There are three attachments of the middle turbinate. The first attachment is the sagittal attachment, where it gets attached between the medial lamella and the lateral lamella. You can see that very clearly. This is the attachment. Now I go behind. Can you scroll it behind? So you see, as I go behind, slowly I'll go behind. Now you see, the middle turbinate is going towards the lamina papyracea. You can see here. So one cut in front. So one cut. So see, you can see that middle turbinate going towards the lamina papyracea, and that is the basal lamella. This is the coronal attachment of the middle turbinate. As we go behind, you see, go behind. So you can see here, this is the horizontal attachment. So you see, that's the horizontal attachment. You can see that. Went off. So you can see that's the horizontal attachment of the middle turbinate. So that's the horizontal. So see that's the horizontal attachment. Can you see that now? That's the horizontal. So there are three attachments of the middle turbinate. One is the sagittal attachment. Second is the coronal attachment to the lamina papyracea, and third is the horizontal attachment. I hope I answered your question.
Yep. Thank you.
Thank you. Yeah. Anybody else having any questions, please? Yeah. So this is the flyer Dr. Harsha has prepared. Thank you, Dr. Harsha. So my friend Professor Anthony is going to do grant rounds, so don't miss it. It's on 20th April, 22nd, 27th, and 29th. 20th we have a ear case. 22nd we have larynx. 27th we have a hypopharynx, and 29th we have a nose. And then after that we have two more. We have head and neck, thyroids, and parotid. So these are the plans we have for the postgraduates who are attending the exam. Yeah, Adi is there. Adi.
Hello.
Yeah.
Good afternoon, sir. Good afternoon, sir.
Good afternoon.
Sir, I'm Dr. Aditya from Maharashtra. Sir,
Yeah.
I wanted to know how high can we cut the perpendicular plate of ethmoid without causing any complications like CSF?
Good. Okay, see, again, I will just go for the screen share. This one. Share. Yeah, this one. Scan, not the scan. See here, let me go to the scan. You will know now. Now I'm going to show the scan. Imagine this is the deviation, right? So your question was how high I can go to prevent the this one CSF leak, right? See here, boss. So if you look at it, see, this is where after the crista only the cribriform plate starts. You understand or not?
Yes, sir.
This is the crista galli. This is the crista galli. After this level only the cribriform plate starts. So what you are correcting is here. See here, this one far anterior. So the only complication you can develop is a little supratip saddling. You can never develop a CSF rhinorrhea here. So it is far anterior. See here, this is far anterior. There's no skull base at all here. So by correcting this here, no skull base. There's no skull base. This is what you're going to correct. This one. So there is no skull base at all. You skull base. See how posterior is. This is where you're going to start the skull base here. So we will not even go near the skull base. For you to go, then you have to go posterior and high, which you are not going to do. So this is where you're going to do injure the skull base. So skull base is not at all a problem in a septal body.
Thank you so much, sir.
Yeah. I hope you understood the answer.
Yes, sir. Yes, sir. Thank you.
Any other question?
Sir, we have few questions in the chat section.
I think we'll take that later. I think we are we've
Sure.
gone beyond time, boss. We've gone 3 hours now.
Nobody has raised a hand, sir.
Yeah.
One.
Then we can call it a day. And OnePlus Nord, I think, is raised his hand. Yeah, you can unmute, my dear friend.
Sir, sorry, I am taking your time.
No, you are not. If
Sir,
any number of questions we can answer, no problem.
Sir, you have just mentioned that the high correction can lead to saddle nose deformity. So to prevent that, how much we can remove?
Yeah, see here. Again, I want a screen share. This one. The same one. Same one. Not this. 1 second, huh? Okay. Now see here, boss. I'll explain it to the. Can you see my screen share now?
Yes, sir.
Okay. See. Okay. Now you see here. This is the nasal ascending process of maxilla, right? This is the nasal bone, right? Okay. Now,
yes, sir.
Anything which you will correct at the junction of the nasal bone or anterior to the nasal bone only will cause a supratip saddling. Please understand. You keep your hand on your nasal bone and see.
Okay.
Where is the key point?
Okay.
Keystone area. That is where you will produce the supratip saddling. You are going behind that area. This is the ascending process of maxilla. You're going behind that area. Only if you go anterior, then you will cause a supratip saddling. So you go behind that area between the ascending process of maxilla and the cribriform plate, twister galli. So this area, unless you will just put a lux and twist it, the whole thing comes out. You have to use a sharp scissors, a thick scissors, and cut it here. So you will never develop a supratip saddling if you don't use a shearing instrument. You just use a cutting instrument. So you will automatically see you cannot reach this vault. To reach the nasal vault, it's very difficult with the endoscope. So you will automatically leave around 1 centimeter easily. So to the middle turbinate, to see the middle turbinate, this is the middle turbinate here. See, this is the middle turbinate. So this is the axilla of the middle turbinate is here. This is the axilla of middle turbinate. So to reach this, you have to just correct only here. So you don't have to go here at all. So you just have to correct this, you will reach the axilla of the middle turbinate, middle meatus. So it's as simple as that. So it's very, very unlikely unless you shear it and just tear the whole thing. And I mean, you have to be a butcher to create a saddle nose deformity.
Sir, for this, you mean we have to keep the quadrilateral septum there only, and we have to break the bony cartilaginous junction and then remove the bone?
Yes, yes. You don't have to even remove the bone, boss. What nowadays I do is I just cut it and leave it. You can just move it.
Okay.
You don't have to remove that completely. Just make a scoring and then leave it like that. Ultimate thing is post-operatively, again, there should not be a buckle, so that you have to follow up that case post-operatively. That is your main aim.
Thank you, sir.
Yeah. So, anything else?
Thank you, sir. Dr. Fan. Dr. Fan.
Doctor?
Dr. Fan. Yeah.
Yeah. I have heard about the symptom of the altoroside in the frontal sinus from the harassment in one of the 5 landmarks in sinus. Can you explain more the meaning of the altoroside when it's
Madam, you're not audible at all. Dr. Dinesh, Dr. Harsha, can you hear the question and tell me?
Yeah, Dr. Fan, if you can type the text there, some audibility issue.
Yeah. On the CT scan, they have the blend the side of the shape like the horn of the buffalo, so they call it the altoroside in the frontal sinus dilator. So that I don't know about the meaning of the altoroside.
Sir, Janakiram sir, the doctor is asking about what is that L Toro sign in frontal sinus. Are you aware of this sign?
What sign?
L Toro sign on the radiology.
I don't know.
You can Google in the 5 landmarks in the Google. You see the altoroside in the medical book. I read in the medical book.
I said the M sign or the T sign. Are you referring to that or?
I have sent you in the picture and the image of that through the messenger interface. You can have a look.
Oh, is it? Let me see.
Yeah. Also, you can open that picture and explain.
Messenger. My Facebook Messenger. I will reply to you on the messenger. I can't see it right now. Okay, any other questions? Let me answer.
Good evening, sir.
Yeah.
Sir, how much should be the opening of the maxillary during maxillary, this middle enterostomy, the ostium, the opening?
Yeah, that and
ideal.
all we'll be discussing very shortly, boss, next time.
Okay, thank you, sir.
Okay, sir, I think we
Oh,
can
you
just
mean the
call
El
it
Toro
time
sign,
now.
is it?
Any questions? Yes, sir. El Toro sign is
Yeah,
what
yeah.
Dr. Fan was asking. Yeah.
Yeah, so basically, if there's pneumatization over the frontal bone or the orbit and behind the frontal recess, which extends lateral to the frontal recess. So that's the El Toro sign.
Yeah.
All right.
Yeah.
Okay.
So you have extensive pneumatization above the frontal recess, boss. That is El Toro sign. It's like a torus.
Okay, sir. Sir, I think thank you, sir, for today's.
I think Khalid Damesha is there. Khalid Damesha is my close friend. Khalid.
Yes, sir. Yes.
Khalid. Khalid, unmute.
Yes. So we have requested to unmute, but they haven't. Yeah,
yes.
Now, yes.
Hi, Khalid.
Yes, good afternoon, sir. How are you?
Yeah, fine. Thank you, Khalid. How are you?
Yes, fine. I am very glad to hear from you today for this lecture. Although I see the late announcement, in fact, on Facebook. Sir, my question, yes, my question. I don't want to waste your time. My question is that if you got a CSF leak, which you might do when you injure the lateral lamella. Do you proceed with the usual process of grafting, or you put just only artificial dura and fibrin glue and that's all? I mean, when you recognize this injury, do you go with the usual steps of repairing CSF leak as an old case of CSF leak, or just to put artificial dura and you put fibrin glue? I saw some of the neurosurgeons here in Jordan. They put artificial dura and they put fibrin glue, and then they put gel foam or something like this.
Okay, let us understand that artificial dura, Duragen, it should be placed as an underlay technique. You cannot place it as overlay. So overlay grafts can be facial atta, it can be free grafts, but artificial dura is placed as a underlay graft. So inlay graft. So if you place it as an onlay, it will go for failure. So actually artificial Duragen replaces the arachnoid. So basically I wouldn't do that. I would repair it as if I repair a normal CSF leak. I'll put a small dumbbell fat and I'll put a little fascia and put a little mucosa over it. So that's how I'll repair it. I wouldn't place artificial dura as an onlay. Never do that.
Yes. Yes, and you put fiber glue on top of it.
Yeah, glue, see, glue, there are a lot of studies. Nowadays, I don't even use glues. They are more of placebos. So
Yes.
I don't use glues much.
Okay. Thank you, sir. Thank you.
Thank you. Thank you, Khalid.
Yes,
Have a great
thank you,
day.
sir.
So we'll be doing a lot of such programs. So Dr. Sri Harsha is in charge of all these. So you will see a lot of academic stuff coming up from Royal Pearl Hospital. Dr. Prakash Munka is there. Wow. I was missing him all the way. Unmute yourself, sir.
Yeah. Hi, Janki. I was listening to you from beginning.
Fantastic, but I missed you.
No, I just wanted to enjoy as an audience because the main message which you have given that nowadays everybody must learn to read their own images. The CTs, MRI never ever just rely on the what you call given the films and the report, because that can be, they can miss out. In this context, one thing I like to add, which I practice as well, if you don't have you are not expert in reading that, at least for the juniors, when you are sending a requisition, you must mention your area of interest, what pathology you are suspecting, so that your radiologist, who is a more learned man, he will focus on that. Like your radiologist, he has enlightened a lot, which probably even by reading DICOM, we could have missed. We have seen in the earlier webinars. So your communication with the radiologist and the requisition, this is a message I would like to give. It should very clearly mention what are your provisional diagnosis and what you are suspecting. That's all. It was an excellent. Throughout, I was listening.
I want to tell you something, sir. It's a very nice statement you brought. See, when I did my post-graduation in Madras Medical College, I did it for 5 years. 5 years, I did DLO. So every time I wrote a CT scan, long time, it was 1998, every time you find me in the CT scan room, I'll be sitting in the CT scan while taking the CT scan. If they take a Stenver's view, I will be positioning it. If they take a Waters view, nowadays I see postgraduates don't go on to the scan room at all. I request all the postgraduates, when you write a CT scan, accompany the patient along with the CT scan. And see, when I went to a training for Professor Draff, you know what he does? Every day morning, his round starts at 7 o'clock, 7 a.m. There'll be a group of postgraduates. Everybody will go to the radiology department. And the radiologist, along with the ENT surgeon, will sit down and discuss the whole thing. So this practice now is completely gone. I'm telling you, nowadays what we see is we can read everything. No, go to the DICOM image. That is the console image.
Yes.
And sit with your radiologist. That's how I learned my CT. That's how I learned my
I think most of...
Yesterday I went there. I was sitting with him. I discussed. So there is nothing wrong in learning every day. Go there, sit with him, discuss. Ask him what are your doubts, why this artery is here. You should have an open mind to go to the radiology console.
I think that is the best option, what you have said. And if I now go into the hind ears, our radiologist always insisted, as a junior when we were working, you please come and push the die. It was not the die. It was, he used to say, later on he said, I wanted you to come for the dye, and naturally, once you are coming to my room in the CT room, you will like to watch it, or I will make you watch. So that is the thing. But what I said is the second best. If you are not able to contact, maybe he is in another town, at least your requisition should be very, very specific.
Yeah.
So
Fully agree.
excellent one.
Thank
Yeah.
you.
Thank you.
Thank you. Okay, so with the concluding remarks of Dr. Prakash Munkaji, we will conclude this and we will meet again in the next session. The next session will be on how to do surgery, that is how to do endoscopic sinus surgery for basic FES or basic sinusitis, and then each scenario one by one. So let us go on to when we will do a big MMA, when we will do small MMA, what are the indications. So many topics will come. Then what is the pre-anesthetic management, how everything will be discussed in detail. We'll start with cadaver dissection. We'll go step by step. That will be our next lecture. And I hope you will all join us. Before that, we have Dr. Anthony's grand rounds as well. I'm sure that it will benefit all of you postgraduates. I'm happy to be back again with you. And thank you and God bless you all. And all the best for your exams.
Thank you, sir.
Thank you, Harsha, for wonderfully moderating. Dr. Dinesh was also there. Dr. Dinesh, really happy that you're taking part. Can we see your sweet face? I can only see table tennis.
Yes, sir. So actually, I'm outside right now in the car driving.
Fantastic. Thank you very
Okay,
much.
sir. Right, sir. Fine,
Thank
sir.
you very
Right,
much.
sir.
Thank you.
Right, sir. Bye, sir.
Thank you.